Okay, we might get going and people can join us along the way. I just thank everybody for calling in today to the Health Services Research Association of Australia and New Zealand's webinar. The association aim is to promote networking, education and training, and build capacity in health services research in Australia and New Zealand. I aim to run these webinars monthly throughout the year. There are 3 events. Priority is given to association members should they fill up, but we do encourage participants to look at our website and think about joining and supporting the association, which relies on its members' fees for the majority of its funding. We also run a biennial research conference. The next one is being held in the Gold Coast at the end of 2017. We issue a regular news, jobs and events bulletin, run a raft of awards and prizes to showcase the best in HSR. And we're also reintroducing our mentoring scheme this year, so emerging researchers might like to have a look at that. And just a couple of housekeeping issues. Delegates should be able to see and hear everything that's going on, but we can't hear you. But you can participate in the discussions by using the buttons that you'll see at the bottom of your screen. You can just general chat and comments using the chat button. And if you've got questions or that you'd like to ask, please put them in the Q&A box. You just type them in and Mark and myself can see those, and we'll relay those to the appropriate speakers, either at the end of each speaker's presentation or at the end of the webinar. And if they're for a particular speaker, you might like just to indicate that as well. And also we are recording the webinar, so that recording should be made available a day or 2 after the event. And I'll pass over to Mark Mackay, who's a senior lecturer at Flinders University and visiting research fellow at the University of Adelaide, and one of the founding members of Cumberland AU, which aims to improve health systems thinking through the use of operations research, systems thinking and design thinking. And Mark will chair the session today and introduce the other speakers to you. Thanks, Mark.
Thanks, Sarah. Welcome everyone, even though I can't see you. It's kind of a little bit odd. Joining me to make this presentation today are my colleagues Keith Stockman, who's at Monash. Keith works as an operations manager, helping improve the services at Monash, and works in conjunction with Don Campbell and Professor Robert Adams, who's based at the Queen Elizabeth Hospital and works at the University of Adelaide. He's a professor of general medicine and also specialises in respiratory medicine and has a big interest in reform and using information. We are all members of Cumberland.au, and I will tell you a little bit about that if I can get my slide to move, which is a bit odd. Yes, Sarah did mention the questions. Use the question box. For some reason, I can't see that at the moment. I can see Keith and I can see Bob, but I can't see the questions. So Sarah will give me the questions at the end. Cumberland Initiative. The Cumberland Initiative actually started in the UK. It promotes the use of operational research and systems thinking in health, particularly the NHS. Its old website used to say its stretch target was to save 20% of the annual NHS budget by 2020. That was a real stretch target, not necessarily easily achieved. It is still seeking to make big improvements in the NHS. They have a website, cumberlandinitiative.org. We effectively have become the Australian branch, Cumberland.au. Our website is coming. It should be here soon. There are a number of us. We are a multidisciplinary group. We involve mathematicians, computer scientists, clinicians. We come from around Australia. It's not just modelers, i.e. the mathematicians and computer scientists and others, such as Keith and myself. We believe we have to include clinicians, otherwise this sort of work cannot occur. We had another piece published in the Conversation recently as part of the series of health pieces they promoted in March. We've also managed to secure a grant in Adelaide, and others such as Peter Taylor have grants in Melbourne, and people are doing work on surgical suite modelling, intensive care unit modelling and other things. And Keith at Monash has been applying this sort of work for quite some years. Some context for our talk today. Leaving aside the fact that we've had a leadership change, the messages haven't really changed. Health in school, even as we enter this election period, the areas that the government's concerned about how much we spend. Should it be slowed? Should it be increased? Points of difference, I guess, at the moment between the two parties. However, that message is consistent across countries. There is also concerns with performance targets that are being used as well. So there's a lot of interest in health from politicians, and the media gets attention. If we look at the CPI over an extended period of time, so going back to the 90s, CPI is the Consumer Price Index. It's a way of measuring inflation, so how much prices are increasing. We can see this red line, that's the CPI. It's for Adelaide. The trend for Australia is pretty much the same. It increases almost in a perfect linear fashion over time. This blue line is the health component of CPI. It is increasing at a much faster rate than CPI. That is why politicians and some bureaucrats are concerned. It represents a level of growth in costs that is well and above the rest of the economy. Why focus on hospitals? In terms of large changes in expenditure by the government, hospitals represent one area where there has been a large change relative to GDP growth over the last decade or so. Now, this data was from 2002 to 3 to the 2012-13. Not a lot has changed since then. So hospitals represent a really big area of expenditure. Yes, the sort of things that we talk about also can apply outside of hospitals, but for a variety of reasons, it's one area that interests us. One of the messages that we continue to notice that people are being told to get ready for change. And this comes across in many areas, a little bit of light relief, I guess. We're preparing the hospital for extreme changes of climate, floods of patients and droughts of funding. So in line with the earlier graphs, yes, we're being asked to do more with less. So let's move on to what a system is. Now, many of you may have already come across what a system is, but it's a system of elements that have relationships between them. So the sum of the parts of the system will always provide something that is greater as a system than they can individually. If the elements or relationship changes, the system will change. Behaviour is emergent, so it has property that none of the components of the system has individually. And there can be subsystems. So our body is a good way of looking at subsystems. We have a body and we have organs. Those organs can be viewed as a subsystem. And we have boundaries. And a system operates in an environment. So why is that important? And of course, system transform inputs from the environment to outputs to the environment. Why is it important? Because often when we view a problem, we ignore the system and the implications of what the system might have in terms of affecting that solution. So if we take a hospital, here's a particular view of the hospital as a system. It's easy to look at it a department. So the emergency department often receives a lot of attention. General medicine might receive attention because of long stay patients and issues around bed block. We can try and fix those problems by just working on one part of the hospital. The ED department, we might add some more beds, we might add some more consultants. However, often the fix does not work or doesn't work for long. Why is that? Because the emergency department or the general medicine department or any other department is part of a bigger system, and those other parts of the system impact on the part we're trying to fix. Now, I've got a little video that explains it. I'm just going to have to get out of here because that video wasn't working well. Where's it gone? Back here.
Well, the term systems thinking is really a mixed bag, and I use it very, very cautiously. First, both words are problematic, but the word system is the most problematic, because if you say the word system, the picture or image that pops up into most people's head is computer system. Like, you know, we need a systems expert here because our system's not working. The second most common association is management control system, as it's not my fault, it's the stupid system. Right? So these are the two associations that come first to people, and neither of them is what we're trying to help people understand. So whenever I'm trying to help people understand what this word system means, I usually start off by saying, are you part of a family? Everybody is part of family. Have you ever been seen in a family, people produce consequences in the family, how people act, how people feel, that aren't what anybody intends? Yep. How does that happen? Well, you know, then people can tell their stories and think about it, but that then grounds people in not the jargon, you know, system or systems thinking, but the reality that we live in webs of interdependence. A family is a fairly close-knit one. You can kind of see most all the key players. But still, even though we can identify maybe on a list of 10 or 15 names, here's all the key people in my immediate family, still the complexity of interactions amongst all those people is obviously such that consistently families produce outcomes that nobody wants, which is the other kind of, you might say, fundamental rationale for all of this. It's not to, quote, understand systems. That's an abstraction. It's to understand how it is that the problems that are the most vexing and difficult and intransigent that we all deal with come about. And obviously, to get a perspective on those problems that gives us some leverage and some insight as to what we might do differently.
Okay, I hope that little video gave you a good explanation, succinct explanation of why we're interested in systems and systems thinking. Peter Sanger is well renowned in this area for his work on systems. One of the things that often gets mentioned with systems is, are they complicated or are they complex? And a good way of thinking about complicated is considering a plane. A plane is complicated. It has lots of parts in it, be it the computer system, be it the engine. Yes, we couldn't individually put it together. It takes lots of people to put it together with lots of expertise. However, when the pilot gets in the plane, they can take off, they can land, they get reliable performance from that plane. It performs the same way every time. So they expect consistent results. That's a complicated system. A hospital, on the other hand, is a complex one. This strange little diagram represents the pathways through the hospital, just a local hospital in South Australia. It represents the pathways of about 20,000 patients. There's about 4,000 unique pathways through the hospital. So it rapidly shows that it's complex. And when you've got a complex environment as opposed to a complicated environment, simple fixes just don't tend to work. So health is one that is not easily worked in. It provides us with some interesting challenges. This is where I hand over to Keith, who's going to talk about design thinking, which is the next step in the our presentation.
Thanks, Mark. And I'll get you to move the slides along as I go, if that's okay.
That's fine.
Great. So I just want to spend 10 or 15 minutes talking to you a little bit about design thinking. And I wanted to cover 4 things. How Don and I got here, and by the way, Don's doing a pilgrimage in Spain and sends his apologies for not being here, albeit with an iPhone and iPad. So it's not quite the ancient pilgrimage of past. What is design thinking, briefly? Some key properties that we've come to understand, and just very briefly, some experiences. I don't have a lot of time to go into detail. Next one. So let's do how we got to here. Next one. Don Berwick made this very oft-quoted statement that every system is perfectly designed to achieve the results that it does, and it was an interesting comment that certainly interested me when I first heard it, because we had long been interested in systems thinking and attempted to apply that both through some long-term consultancy work that I did, but also with my work with Don over the last 10 years or so. And it really highlighted the point that system mattered, which we were terribly interested in, and we loved doing simulation models and things. But the word design got ignored for a long time. And I want to talk about that a little bit. Next one, Mark. Next slide, thanks, Mark.
I've changed it, Keith.
Yeah. Along the way, that one of the things we found out is that a lot of the systems in healthcare, whoop, too far. Back to dominoes. If we,
There's a delay.
yeah, it's like steering a ship. I'll wait till it comes up. Is the notion of the domino effect, and I think there's quite a bit of work over the years where we managed to create unintended consequences through our efforts to be systemic, and I think that's been a painful lesson at times, but more and more we've come to appreciate how to deal with this. Next one. I'm still seeing dominoes. Yep. One of the things that's been very useful in recent years is the Cynefin framework, which was developed by Dave Snowden, and I think it gave us an accessible way of ourselves and talking to others about the nature of the systems we were dealing with, and how we actually went about the design process. So on the right-hand side, it's a simple and complicated space, and these are systems where, with the right expertise and knowledge or common sense, some understanding about cause effect can be had. Certainly in complicated, you need engineers and experts, and that's the land of good practice. But more and more we came to realise that we were actually trying to design systems that might be suited for complicated space that were actually in a complex space. And the way one goes about that and the emergent nature of systems or health can be put in there for people with chronic complex disease really needs to be quite different in its nature. And one of the things we've discovered is that design thinking, whilst it's very effective for complicated, it's also an interesting and developing space for working with designing complex systems. I won't go into chaotic. Next one. We were very fortunate in the beginning of our work with design thinking to meet and have out to Australia Harold Nelson, who's written this excellent and challenging book called The Design Way. Harold was, as a past president of the International Systems Society, and has spent 25 years thinking about what systems thinking and design has to offer and how it fits in with science. And I really recommend this as a book to you if you're deeply interested in this subject. Next one. The interest in systems thinking is spreading. Don, about 18 months ago, did a tour of the US and found designers and doctors and nurses working in design centres, very actively using the systems thinking practices at Mayo and Kaiser and various other places. Our New Zealand colleagues also are moving down this track, and we're in our early phases here in our own little thing, and through Cumberland beginning a journey with this. It's interest in the design profession itself, in the design of systems and services, rather than posters and toasters, is also growing. So we have a lot of contacts that we've developed into the design universe that want to work in healthcare. Next one. So let's just play a little video just to show you very quickly some insights into design thinking, in particular service user experience design as it's seen in the outside world.
Services for everyone, from how you plan a trip to how you get your first job. Services can change how you respond to an emergency. They allow meaningful connections and interactions and can change the way a business is run. While services have been around forever, consciously and carefully designed service experiences are new, and they are often the key differentiator that make us return to the same brand, product, or company over and over again. As we move from commodities and goods to services and experiences, giving people what they really want is a way to gain or maintain a real competitive advantage. We all expect good customer service, but when an experience is well orchestrated, we don't remember the service. We just remember how it made us feel.
Yeah, and just mobility.
So what can service design do for your company? It can increase profits by 20%, even when you've already captured the market. It can grow margins and streamline operations in the midst of an economic downturn. It can create solutions that attract millions of new customers in less than a year, or it can redefine your brand's reputation in a tough global marketplace. Too often, business insights don't lead to real customer satisfaction, or customer insights don't lead to business results. But by working in collaboration with your employees and your customers, service design can make a company's offerings more usable, efficient, and desirable to create solutions that build value, not only for your customers, but for the bottom line as well.
Okay, if we can get the next slide, Mark. So, whilst that's a bit of a glossy brochure, a video, it makes some very good points about designing for user experience, and we certainly view users as both the consumers we service, but also the staff that must deliver that service as well. I was cynical about all this at the beginning, but when we actually went out and had a look at what was happening in the outside world, in banks and other places, and in retail, looking at how people were actually designing service experience for their customers, we really realised just how far behind health is in that thinking. But we're slowly catching up. I found this little diagram that I'll just sketch down here quickly interesting, which comes from the business partner of Russ Lakoff, Jamshid Jamjaji, and he makes the point that design is in its own space, as does Harold Nelson. And while science is about finding similarities amongst things that are different, and art is about finding differences amongst things that are similar, design is really about creating feasible wholes from infeasible parts. And so let me just tell you a little bit about what we think that means. Keep going, Mark. Sorry. This is a very famous slide in the design universe, and was made by a guy called Bill Moggerich, who was a designer. And as user experience is becoming more interesting and the demand for innovation in that space, he pointed out that this was at the intersect of what was desirable from a human perspective, what was viable, and what was technically feasible. And of course, all these move all the time. So it's a challenge. And what sort of methodology do you need to actually work in that innovation space effectively? Next one. We have got to know a chap by the name of Hugh Dudley, which we're hoping to have out to Australia next year. Hugh is known as a super modeler in the design industry and does all sorts of interesting things like redesigning massive systems like the American voting system. And he points out that design is all about bridging the gap about what is, which is very much about analysis and science, and looking at what could be, or as he says on the next slide, what should be. Next one. It is like steering a ship, isn't it?
It is.
You have to wait for the reaction. We have been working with Jean Liedtke, who is professor at Darden Business School in Virginia Uni in the US, who has been the author of I think 4 books now, trying to bridge the world of MBA and MBA students and design thinking. And she has very much codified a training process which is suitable for people who are beginning their journey on this. I think it's very important not to get caught up on the mechanics of design thinking too much, but Jean has really made some fantastic material to do this. We've used this here in Australia on a couple of test groups, and we've also given training at some other hospitals using her approach. And we're working with her at the moment to develop a health-specific version of this training. You'll see from the what is, what if, what wows and what works that this bears a lot of relationship to any other cycle like PDSA cycles and so forth. But there's some very distinct differences about the stance and philosophy that underpins what you're doing through each of those steps. And that's where the juice really lies. Next one, Mark. So there's some key properties I just wanted to quickly mention, and this is not comprehensive, but there's some things that I think really matter about the stance in design thinking. First and foremost, it really focuses on it's really human-centered, looking at how people actually experience things and what their needs and desires are. I thought we did that in health till I hung around with designers and I realised that they have tools and go to a depth level with this that really is quite phenomenal compared to what we've done in the past. And they get very good at being empathetic and putting themselves in the same positions as patients, for example, to truly understand what things feel like as much as you possibly can. And they have many methodologies to do that. They also go to a lot of trouble to do what we all should do, but maybe a bit lazy on, and looking at a lot of perspectives. But this is taken much further in design thinking than I've typically seen in the past in healthcare projects. They also have this interesting notion that any constraint, like it's got to be cheap, fast, and whatever, is part of the fun, and they very much take a playful approach to working around these things. It's often younger people doing this, full of energy, and it does encourage any sort of person, I think, in the process to be very creative. Next one. In design thinking, one stays in the space of divergence, creating a lot of different ideas way beyond the typical brainstorm that we would have typically done before going into the process of convergence and synthesis of ideas. And we sort of came to see design thinking as systems thinking in action. And I'm a great fan of Kevin McLeod's Grand Designs. And on one program I was watching one night, he said, good design often represents the resolution of conflicting ideas. And I think that really sums up the whole process of synthesis and working on whole systems. Next one. We've also come to appreciate that designers use models and visualization very extensively, all sorts of models, including computer models. But an interesting thing is when one starts to frame the notion of models and stories and how they interact, like they're drawn out there, that stories create models and models explained by stories, actually is a conversation space we're developing at various stages through the work. No model, no conversation, no design is an interesting way to view this. And a lot of design people will talk about the fact that design is actually improving the speed and quality of conversation as much as it is about anything else. And they have a large set of tools to facilitate that circular model on the right. Next one. Hugh Dudley has pointed out that there's a standard set of models that designers tend to use, and all sorts, to bridge the gap between all the people who are shown in that diagram in the creation of new things. And I think, again, that's an interesting stance where this is very much about bringing together interdisciplinary knowledge to create new things, new desirable things. Next one. There's a great deal of use in design thinking of prototyping. Rough things built from cardboard. We just took delivery of our first set of serious Lego. Making things with your hands in teams with people looking at new concepts is extremely powerful. Getting people to learn how to diagram and to draw concept models and also developing mathematical and computer models is all very useful in the design cycle that's represented on the right that I won't go into. IDEO, one of the most famous design groups in the world, pushed the fail often, fail early concept. Prototyping is very important to interact with users and rapidly develop how one can test new ideas out to give them their best chance when they come into the world. How am I going for time, Mark?
Going fine, Keith.
Right. Next one. So quite a few people have asked us, well, what's different from the redesign we've been doing for years? And the first thing I say to people now is, look, it's just complementary as a problem-solving approach to any of the things that we've been using, Lean, TOC, Six Sigma, etc., over the years. It's just that it happens to have some advantages in some of that Cynefin framework space up on the left top side in the complex domain, where we find a lot of wicked problems which are very complex in health. And therefore it becomes an important tool in the armoury. There's a lot more emphasis on consumer experience and their needs from multiple perspectives, which I mentioned before, and it's much less prone because of the stance one takes at the beginning of a group picking up on their favourite solutions and having another go without actually realising why it didn't work last time. And we see this so often. We try and repeat the same simplistic solution and fall flat on our faces. It definitely encourages creativity, more so than I've seen in any other project work in the past, and I've done a great deal of that. And co-design in this with consumers and users goes way past asking what do you want to actually really building systems and asking people to experience them and feedback on them, which is a powerful way to go. Next one. Just very briefly, and we're embryonic in all this. We don't claim to be expert. We're a little ahead of the pack, but we are doing a very sizable project on avoidable hospitalisation using design thinking as an approach. We've had, I think, some really good breakthrough thinking as a result of that, and I hope also it's helping us take a systemic design to looking after people who general medicine does a lot of inpatient care, but we really lose track of beyond that. So that's a project we hope to report on next year. We did some very interesting hand hygiene work with a guy called Tim Evans from User Experience Group at Isobar. Tim came and had a look at how we audit hand hygiene and so forth as an exploratory exercise using various design approaches, including filming and such things. And really just blew some of our myths about what was going on with hand hygiene out the window, not the least of which was making some very graphic video of what happens when our audits are going on versus what happens when our audits are not going on. That work is now going into a project with the Monash Arts and Design School. As we hope to take that into a grant, and we've got industry partners looking at some of the information that's come out of that hand hygiene work, trying to create some new ways of encouraging people to do the right thing. We're just starting off. In 2 weeks' time, we have our first Makeathon series, which is otherwise called the Design Jam. And we've invited a number of design companies to help us learn about this by having one-day design exercises with groups of patients and staff who and look for new ideas that might be interesting. So the first one's on paediatric adult care, and should be a really interesting process. I've done work on long stays and development of quite novel application, which we're about to start to use for tracking what's going on with people and predicting their long stay risk. And again, we hope to get that out and get that out in the literature over the next 12 months. We did a very interesting exercise with a number of our executives on arrival at hospital during one of the design courses, which ultimately led to a whole lot of changes as to what happens at the front door of our Monash Medical Centre. But it's very interesting, with the right tools in hand and the right stance, we very quickly, in about an hour or two, realised there were a huge number of flaws in the way people were being treated on the way in the front door and how they experienced it. Not the least of which was a number of people coming with letters that we were writing for various departments, which were so difficult to read that people were actually at the wrong hospital, and every department did it differently. And those sorts of things are things we just take for granted, which design thinking says, no, go see. Our mental health team has done some fantastic work with moving patients from being caught in a trap in emergency care in the community and not actually receiving much therapy to rapid access clinics, which came out of the design thinking process. And that is very much Melissa Casey and David Clark, who've done that wonderful work, and they won a state award for that about a year ago. And last but not least, I want to mention a project we did in community, which is my first one in design thinking for me. That led to an interesting end. We ended up with a model that looks very close to the extremely successful Dutch model, Bertzorg, which has since occurred. But the big lesson for me in that was implementation can be approached with good design technique, including design thinking, and we need to be as innovative with getting it done and implemented as we do with designing the concepts. In other words, all design has a very major political dimension which has to be part of the design, and that was a pain point for us, but we've learnt the big lesson. So I think that's it for me, Mark.
Thank you, Keith. Do you want to comment on this slide?
Sorry, there was one. I'm sorry. So the challenges moving forward are finding ways of getting training material suitable for health people and skilling them up. And that's what we're doing with Jean Latika, and we hope to make that available to everyone once that's done. She's also bringing out a book with some of our case studies in it, which should be out in the next 6 months. And finding adequate time and creative energy is a challenge in hospitals because people are so drowned in work. And I think we need to do more work on how we create those spaces for people. We're working very hard to mix it with designers outside and expose more people to them because we think we have a lot to learn. Harold points out that you really need organisational nurturance if you're going to do user experience, human-centred design. And I think that's a big journey for everybody to figure out what that looks like in a hospital. And of course, we have the issue of evidence of value of all this. And if I could flip to the next slide, Mark, sorry. Ultimately, we need scientific evaluation, which is what some of you will be expert in, so to actually judge whether design thinking itself is producing any sort of different outcomes than what anything else has. And I think we need to turn to our friends in health services research and really use that scientific evaluation approach to question, in due course, whether we're actually making a difference with this approach. We feel we are, but it needs to be proven. Thank you very much.
Okay, thank you for that, Keith. That was really useful and set up the design thinking side of things quite well. Some of the next slides are really to emphasise where people, particularly in the Cumberland Initiative in the UK, have been applying simulation and systems thinking. The UK people are aware of our interest in design thinking, but they're slowly moving to that. They're not yet necessarily fully on board with the design thinking aspects that Keith has talked about. I guess rather than following the UK, we're joining them and in some ways leading them in the design thinking side of things. But all the things that we've been talking about, be it systems thinking, simulation, the modelling that we tend to do to represent journeys through the system on computers so we can test it and improve it, can be applied in a number of ways. So ambulance journeys, Paul Harper in the UK has spent a lot of time looking at where to locate ambulances. Adele Marshall, who's currently in Australia, has spent time with working out whether you should build new ambulance stations, or indeed her solution to one of the problems she was looking at was to have ambulances that were essentially floating vehicles. They would be based at intersections around the city, not necessarily in an ambulance station or at a hospital. Operations management, a message, a definition for it. It's really about planning and control of processes where we're trying to transform an input into an output, and it brings together many areas of study. So organisations, people, and the economics or finances, plus some tools. Historically, it came out of World War II, had a strong bias in engineering and physics and maths, but there is a large component that implies that it's just not the maths or computer science or stats or engineering, but it's judgment and art. And that's why it connects so well to the work that Keith's doing at Monash in design thinking. Simulation tends to be written about in health, but not necessarily used a lot. You may have encountered it as little models of people running across screens. Typically, we tend to use discrete event simulation, but there's other sorts as well. So systems dynamic was the early model I showed on the slide. There's also agent-based, which is now becoming doable because of changes in technologies. There are many, many papers where people have created simulation models around hospitals, particularly emergency departments. They've done one model, made it unique for that hospital, as opposed to a generalizable model that could be used in a number of situations. As Keith mentioned earlier, one of the challenges for all this work, be it the design thinking or simulation, is a lack of evaluation. And Phone and others back in 2003, and I believe also more recently Sally Brailsford and others in the UK have highlighted the fact that there is a lack of evaluation of whether the models are making impact. That tends to be because people either move on because their grant funds run out, or we tend to find health here, there's not enough money provided for evaluation. So simulation model, it's just a computer model. Sometimes it's represented as a scheme of a service. It's good for asking what if questions, enabling testing of a solution before you actually implement it. It also enhances understanding. One of the big findings we find in doing this sort of work is not necessarily the actual end product of the model, but rather the journey that the people go on as the model is created. Providing it's done hand in hand with those who work in the service, there is a lot of learning that occurs. People discover a whole lot of information that previously were myths or unknowns, and it can be quite valuable. What we're not talking about in terms of healthcare is the educational simulation where mannequins or other sorts of devices are used for training purposes. That is a very, very different sort of simulation, and at the moment is causing some problems in terms of language. People will say, oh, simulation, you're talking about mannequins. No, we're not. We're talking about process improvement, design improvement, and the use of computer models. This is a little model that hopefully will work. No, it's not going to show. This is a model that rather than get it to run elsewhere, because it's not running on the screen at the moment. I think it's due to memory constraints that we're facing. I'll make sure it's available for upload on the slides or the video link that you get later. It shows little ambulances and private vehicles moving around Adelaide and what might happen if emergency departments are changed. This model was done using publicly available information. It was created in a few days, but it highlights the graphic, the way in which information can be provided in a graphic way that people can understand and can engage with, as opposed to just creating a table of numbers and saying, well, so many patients, this is what's going to happen to the National Emergency Access Time targets if you change the resources in hospitals. So much more engaging way of producing a tool that can facilitate discussions. So why do we do simulation? It's a good way of testing the system before introducing actual real change. It's safe, it's relatively cheap, or certainly a lot cheaper than implementing a real change that doesn't work. And you can test many, many more ideas than could be trialled in real life. The Cumberland.au group believes that bringing together operations management, design thinking and systems thinking is where we're going to get the best solutions, right in the middle here. But of course, it also has to occur in an environment where there is sufficient resources and also support from leadership. I think Keith and Don would say that the work that they have done would not have occurred if there wasn't support from their senior management. That is pivotal to facilitate this sort of investment in improvement. Giving some context to operations management, ambulance ramping certainly can be looked at as an issue using operations management. ED overcrowding, so models of emergency departments, they can be investigated. Are there enough beds? And currently we're working on a modelling exercise with the Royal Adelaide Hospital around its intensive care unit and looking at the number of beds it has as it moves into the new Royal Adelaide Hospital. Will it have the right number of beds? Waiting for services, can queues be improved? How many resources are required to change the time people wait? Logistics, something that is often forgotten about. Hospitals require all sorts of equipment and services and other inputs to make the services that they provide happen, be it the gloves that are used by healthcare professionals through to food that patients eat. So improving logistics is really important. Also, looking at the amount of time people work and spend doing work. So I was involved in a study in 2007 where we actually tracked, it was an observational study where we followed doctors around hospital to find out what they did during the day. We found a lot of time was spent on logistic support. That was code. It was roughly 10% of their day was spent waiting for things to be found or provided to them. If they could regain or have use of 10% of their day to spend on other things, such as research, where they were wanting to do things, had no time, that would be a huge gain in terms of the value that they could contribute as part of their work. Forecasting, another area where this can be applied, and looking at variation. So how do we improve things? So this was a graph of that was created by Stephen Duckett and back in 2004 as part of the Grattan Institute report, where they're looking at high volume DRG for cholecystectomies and across 5 different hospitals. Why does this variation occur given all these hospitals are supposedly churning through a large number of patients? We can see one hospital had a median price of 4,000. The other hospital had a much wider spread and a median price of 8,000. Can we improve that? Clearly, not all hospitals are the same. And this is where I hand over to Bob, who's going to talk about stroke care.
Thank you, Mark. What I would like to do is just briefly go through a couple of points related to some of the stuff we've been talking about and some observations around the clinical aspects of this and some of the evidence that's been published around simulation modelling. One example comes from the NHS, which was done by one of the members of the Cumberland group there, where they looked at managing stroke patients. And what you'll see is that some of the changes that they recommended, having been through a modelling and design process, have actually been implemented in a number of other places elsewhere in the world by now, including some institutions certainly in my city. Having been through things, they found that one, that taking an ambulance, bypassing the triage process of accident and emergency with suspected stroke patients and alerting the stroke team and getting them activated directly saved time in initiating management. And secondly, if someone came in as a walk-in off the street, the A&E nurses triaged them directly to the stroke team, bypassing physicians in the accident and emergency department. As a result of that process, the trust that was initiated in saw 4 times as many stroke patients in half the time. Next, thanks, Mark. The objective of the treatment was to improve thrombolysis, which is the clot-busting drugs that are now recommended for most types of stroke, so long as they are given within an appropriate time frame. And you can see from the graph that prior to the project, something like 2-4% of patients who presented were available for that. Afterwards, they managed to get sustained improvements up to sort of 15-16% of stroke patients were getting the thrombolysis, which is clearly not all of them, but a number of patients aren't appropriate for the treatment, and it is a difficult gig to get this all synchronised. The reason being, thanks Mark, we get that, is that treatment is really at best effective within 90 minutes of the first onset of symptoms, and people take a while to get themselves to hospital. But can be effective particularly up to 180 minutes or 3 hours after the start of symptoms. You can see from this graph that they found that they got a much larger percentage of people in that particular period of time, and also got improvements in their outcomes from that. So not only did they improve the process, they improved clinical outcomes. Next, thanks, Mark. The obvious question is, why do we need to model? Because you might think this is all blindingly obvious and we should just get on and do it. And a lot of initiatives tend to come down to asking stakeholders and experts what they think would work, and they come up with a solution and then this just happens. Unfortunately, lots of obvious improvements don't get implemented successfully, and certainly don't get implemented in a sustainable way. Part of the issue around that is you need to convince an awful lot of people to change what they do, and what they're doing at the moment, clearly a lot of people think is pretty reasonable and appropriate conduct. One of the advantages of modelling something out and demonstrating that you'll get a certain effect if you change behaviour is that you can present this to clinicians and people doing the work and convince them that the changes are probably worth going with to at least see if they will happen. So one of the tools of this simulation process, beyond just showing that it can be done, is to actually use it as a means of convincing people that the change can be done and can be effective. Next, thanks, Mark. The other thing I just want to briefly touch on is, and it goes to some of the things we've been talking about previously, is the notion of averages. We spend a lot of time looking at data in healthcare to look at average and present a lot of performances in terms of average length of stay, average wait time in emergencies, average time to get something done. And the problem with that is that the grade doesn't necessarily tell us what is happening on any given particular day, or tell us the sort of capacity and how to manage what is going on in a particular situation, in a particular area, on a particular day. And I could give examples in health, but this is a rather neat way of how another organisation many years ago found out that average didn't necessarily apply to human beings or in designing their equipment. Next, thanks, Mark. What the US Air Force found was that in the 50s they used to get a lot of accidents. In fact, they used to lose something like 15% of all their planes. And the problem was thought to be cockpit design and size, and the solution was that they would work out what the average dimensions of pilots were and design the cockpit around that. So they measured 4,000 pilots. Someone then chose to ask how many pilots actually were average. So what they went and did was measure 10 physical dimensions, arm size, hand size, height, weight, whatever, and they defined average rather generously as the average middle 30% of the range on each. They then went back and looked at their 4,000 pilots that they measured and found that not a single one of them was within the average range on all 10 dimensions. And less than 4% of them were average on any 3 dimensions. Meaning that when you think of something that is average and use more than about 1 dimension for it, you suddenly don't really get very many average people or average things going on. Next, thanks, Mark. The conclusion from this was that there was actually no such thing as an average pilot, and if you designed a cockpit to fit it, you designed it to fit no one. And was pointed out by the person involved that the tendency to think in terms of the average man is a pitfall into which many of us blunder. It has had important knock-on effects in everyday life. Pretty much the entirety of the inside design of a car these days goes back to this insight. Because what the Americans then went on to do is design things like moving seats, moving belts, moving steering wheels, and the ability to change things so that they will fit more to the individual rather than the average. And the point made is that any system designed around an average person is doomed to fail, because environments tend to need to fit the individual rather than the average. Thanks, Mark. And so I think when we're designing our systems, we need to kind of take that into consideration. It's a table here taken from a paper in Quality Safety Healthcare. Just shows some of the examples of where this approach to change has been used. Similar examples to the stroke one has been in orthopaedic services, and also by cardiac surgical units. There's been other groups that have done sort of geographical modelling around how you design and where you locate hospitals, improving access to therapies, and some things like capacity management for emergency services, some of the things that Mark has already mentioned. And outcomes from those have been evaluated and published. And to go back to what Keith was saying, I think it's important to recognise that we need to not just say this is a wonderful thing, but actually demonstrate there is a change and an outcome from it that gives you a real output. Thanks, Matt.
And I guess we're drawing to a conclusion, but it's not just us who are advocating that we should shift to a more time of using models and things like systems thinking. Anecdotes, and I'm involved in teaching healthcare management, and from my experience of working in hospitals, anecdotes have been used to, or myths have been used to be the basis of running hospitals or parts of hospitals for a long time. However, anecdotes don't actually necessarily work. They can distort our perceptions, and they can lead us down the wrong pathway. So we should be to rely on data and to model the effects of new policies. So while Stephen Duckett was talking about policy in terms of larger change in the health system, we're also keen that this occurs at the operational level and how services are delivered. So how is this going to happen? Organisations actually start to need to invest in changing their mindset and skills so that it can occur. So how does that happen? It starts with a good question, and why do good questions matter? A colleague pointed me to the work of one of his PhD students in New Zealand. He was very keen to set out to determine an algorithm for improving hospital capacity. He came from an engineering and maths background. He determined that it couldn't be done. Rather, he's actually asking the wrong questions. So he spent quite a few years working out that what he set out to do couldn't be done. One of our colleagues in South Australia, who's been involved in the Cumberland work, did a simulation project, and it took them a number of years to realise that the questions they'd been asking were the wrong questions. Sometimes this is just learning that has to happen because we're coming from different backgrounds and it takes us a while. Other times it's about learning to use tools to visualise questions such as concept mapping and ask the right questions earlier. So what does it take to ask a good question? Understanding the constraints, the politics, the sort of methods that can be applied, the time that you've got to do the work in, who are the stakeholders. These are all common sense sort of things that, yes, probably nodding, yeah, I do that all the time. Knowing what the real problem is. Now that sometimes isn't as easy as it seems because people start out asking one question and really they're trying to ask something that's entirely different. Understanding it's a system that you're working in, and also understanding your own biases. So you come to the table with a number of preconceptions or pre-training that may be affecting how you look at problems. Context alters the frame or the perspective. So this next slide, hopefully you can see it now, has 3 images on it. They all look different. They're all of the same thing. So the image on the left is a side view of the thinker. The image in the middle is just part of the thinker's head. And the third image on the right is the thinker from a different perspective, and also just looking at a shadow on the ground. So we're all looking at the same thing, but they're very, very different perspectives, and you don't necessarily see the entire picture. And it just depends on the view that you're taking. So there's the image that was used to generate these views. So understanding the characteristics of the project, context and boundaries, the participants' perspectives, the politics involved, the ethics, and putting yourself in the middle there helps to work out where the problem is and the environment that you're in, and hopefully helps you to work out what you might be able to do in terms of addressing it. How do we do it? Work in this space to take to make it happen. It's not just the responsibility of doctors or nurses or academics. In fact, it takes a whole team of people. They may come from a background of mathematics or statistics or computer sciences. They may be clinicians as medical officers or nurses or allied health people. They could be social scientists or business people. It's a very much a multidisciplinary space. What's happening locally? As I mentioned earlier, there's a website coming soon for cumberland.au. We've got our email addresses at the end. If you want to learn more about what we're doing, feel free to get in touch with us. We are planning a conference that includes Hugh Doubley and Terry Young. Terry is the director of Cumberland Initiative in the UK, and Keith mentioned Hugh previously. It's actually October this year, not next year. And of course, there are courses around that you might take. I've met clinicians who have done MBAs in where they specialised in simulation. I believe Keith's MBA specialises in simulation. There are Masters of Health Administration. Our Flinders Uni one includes a subject on operations management. It's very much an entry point into this sort of space. There are whole courses. University of New South Wales is offering a 2-year masters on complex systems. So there's a whole variety of ways to learn about this sort of work. And of course, getting involved in projects is another way as well. And finally, know your business. All of this is really providing you a way of understanding your business, how it functions, its strengths and its weakness, and of course, you need to know about its resources as well. Simulation and the operations management tools, and also design thinking and systems thinking. These are tools to help people know their business. And while this slide is perhaps a little blurry, it's probably what we've all been guilty of. The cartoon has someone who's dropped their quarter, and a policeman is asking, did you drop it here? No, I dropped 2 blocks down the street. Well, why are you looking here? Because the light's better here. Well, that's the same as the way we've been tackling some of the problems in health. Why do we keep tackling them in the same way? Because it's easy, or we're comfortable in doing it that way, not necessarily because it gets the result that we need. And moving into the using things like design thinking, systems thinking, is probably going to be a very good thing to do in the not too distant future. We strongly encourage you to consider it. Thank you very much for listening to us, and I'll see, there's our email addresses. I will see if I can see the questions that have been asked. It's flashed up. I may have to stop sharing my screen to do that.
They should be at the bottom of your screen.
There they are.
Mark, Q&A. Yeah. And you got
okay. The first one, and this one's probably one for Keith. Sienna Davidson asked, what's the relationship between design thinking and systems thinking? Keith, do you want to touch on that?
Yeah, sure. It's a big question, and maybe I might share some connections to a bit of literature on it. I think Hugh Doubly probably has made the point well, and in basically saying that designers who are working in a complex space who do not have good systems literacy, and that includes obviously systems thinking, really struggle to design in that space. So in a way, it's a set of skills that need to be put together with the other things that have been developed by the design industry that we can learn from. But you know, it fits with whole journeys, with a holistic approach to things. That's very much part of the designerly way of doing things. It's you know, looking at the dynamics of things, the user experience, behaviour and patterns over time is often taken into account in the design process. So Russell Ackoff pointed out that the future of systems thinking was likely to be design thinking in 1972, and of course he was a very famous and incredible mind, but we probably didn't pay much attention for about 30 years. But I think he was right, and it's the more I've got my head into systems thinking and then eventually design thinking, the more I've realised just how similar they are and how much they have to offer to each other.
Thank you for that, Keith. And I guess this next question is also something you probably want to respond to. Rachel Fleming asks, how are the people or teams you're working with responding to the idea of you as a design shop, as design as a valuable part of the process, or how are you selling design that provides value for money?
That's another big question, but I'll hit on it. First of all, we're not trying to sell it. We're working on the theory that we should do things and be seen, and people might be pulled towards it if we get it right. And I think that's the best way to go. So we don't actually have a design shop. We wish we did here, but that hasn't eventuated at this point. So when we take people through projects that are founded in design thinking, they all enjoy the journey, and they learn to see things differently. And slowly but surely the word spreads through the doing. We're very much hoping that Jean's Latika's training enables us to do this for a broader group faster, and putting a health touch to it, I think really will help health people relate to some of the ideas and how to use them in their normal practice. But there's a lot of challenges, so we've got a long way to go on this.
Thanks, Keith. I noticed a couple of people were asking about the video. I'll make sure that that's available with the presentation that Sarah uploads because they couldn't see it. Another question from Rachel Fleming about Sinn Féin isn't used much in New Zealand, as far as I'm aware. Is it well known and accepted in Australia? Keith,
well,
you want to answer?
Intriguingly, Rachel, I had my only 3 days of training with Dave Snowden in New Zealand, and in fact, nearly everyone in the room was from New Zealand. There were a lot of banks and other business people there, not much from health. Few people from Australia from health. Yeah, Cynefin is is a useful lens. So you don't actually do it as such. It's really just giving another perspective to. It's not a methodology. I don't think it's a reframing mechanism, and I think Dave Snowden's developed a number of techniques off the back of that, which are definitely methodological. Some interesting ones are his SenseMaker product, which is a way of capturing large numbers of stories and doing pattern analysis with metadata created by the actual storyteller, is a very interesting spin-off from his work with Cynefin, which all started when he was at IBM, of course. If anyone's interested in just getting an overview of Cynefin, there's a Harvard Business Review article from 2007 by Dave Snowden. Also, there's an excellent website for his company called Cognitive Edge, which is rich with material from the complexity science world and Cynefin.
Thank you, Keith, and thanks for correcting my pronunciation. Have we considered developmental evaluation as an evaluation approach? Not here. Keith, have you considered any developmental evaluation as an evaluation approach?
No, but we've started talking about how to work with our health services research people to look at evaluation. This is getting a lot of emphasis on that on this project about chronic disease that we're doing. So I can't answer the question yet. I think we really, yeah, it's a difficult process to figure out how to evaluate some of this stuff because the ground's moving in so many other ways at the same time. But any ideas on the approach? Someone would like to have another hour on the telephone talking about evaluation of design thinking outcomes. I'd love to have it, and I'm sure Don would too.
And the last question is using modelling a way to bridge paradigms that underpin design thinking versus the scientific biomedical model that is prevalent in health. Certainly using modelling as a way to bridge paradigms. Bob, do you have any views, or Keith?
I mean, that slide I showed of the three axes of art, science and design very much speaks to that, and all of them are important, and they are artificially separated in a way. But I just think that, you know, I had a traditional science background and I was very stuck in the science paradigm and just didn't realise what I wasn't seeing as a result of that. And I've tried to become a more rounded person as I grow ancient. And I really have come to believe what Harold Nelson says is design is a distinct domain, just as art is distinct from design as well. Herb Simon's book on the science of the artificial is a classic in the design world and a really interesting read, but you'll learn an awful lot if you buy Harold's Orange book.
All right, that's all the questions I think, Sarah. So is there anything else you'd like us to do before we complete this session?
No, I'd just like to thank Rob, Mark and Keith for their presentation, and obviously if you've got any other questions that you want answered, you can send them through to me and I'll pass them on, or they did provide their email addresses as well, so those will be on the slides when we issue them. We'll issue the slides and a recording of the webinar in the next couple of days.